I'm Alison Edisbury and I'm a dental hygienist and therapist working in general practice in the North West. I qualified in 2009 from the University of Liverpool and I'm also representing BSDHT as the North West Regional Chair. We've come a really long way from the role of the dental hygienist being merely to provide a scale and polish. The general public are becoming much more aware of their health, including their oral health and the impact that this has on their overall health. Patients are now seeking out the care of dental hygienists and therapists via direct access, and we are being utilised much more in practice. And it's great to see fellow hygienists and therapists pushing the boundaries of the profession and using their full scope of practice. My role is to help people to maintain or achieve health, specifically periodontal health, with the continually emerging evidence linking periodontal disease to general health, such as uncontrolled diabetes, cardiovascular disease and Alzheimer's disease. My role also has an impact on reducing risk of these diseases. The Economist white paper, Time to Take Gum Disease Seriously, the societal and economic impact of periodontitis, highlights the need for better integration of dental and general health care, and I believe dental hygienists and therapists could be instrumental in bridging this gap. I would love to see dental hygienists and therapists be better utilised within the NHS system, and I would particularly like to see a kind of Tier 2 recognition for dental hygienists and therapists who have gained further qualifications such as a postgraduate diploma or a master's, for example. We are a highly educated and skilled workforce who, despite the advances, are still hugely underutilised in improving not only oral health of the nation, but also reducing the possible risk of systemic disease as a result. I often see patients with mild to moderate periodontal disease. At this stage, there usually isn't any pain or symptoms other than bleeding on brushing, and so it can be difficult for patients to understand that there is a problem and that their behaviour needs to change in order to prevent disease progressing. Most people know and follow the common oral health messages. The Adult Dental Health Survey of 2009 found that 75% cleaned their teeth at least twice a day and 76% used a toothpaste with the recommended amount of fluoride. Despite this, the Adult Dental Health Survey also found that 66% of patients had visible plaque on at least one tooth and 68% had calculus present in at least one sextant. Every patient is different, and the way that they brush their teeth or the incidental aids that's best for them varies from person to person. Tailored oral hygiene instruction is the optimum way of improving a person's oral health, but I find that some people can be averse to being shown how to brush more effectively as they believe that they're already doing what they need to. Habit is also something that is really difficult to change, and just because we give the patient the information, it doesn't mean that oral health will automatically improve. Habit and behaviour change takes time, and we need to discuss this with our patients. In order for patients to change their behaviour in regards to improving oral hygiene, they need to understand the harmful consequences of disease, their own susceptibility to the condition, and how change will benefit them. The first point of call is education. I like to show patients as much as I can, so I draw pictures, I show them the radiographs and periodontal charts, as well as showing them in their own mouth what I'm seeing and what this all means. It's like putting together the pieces of a puzzle. I listen to what the patient is telling me and I draw on this to hit their pain points. Patients will often tell you what their concerns are. For example, they may have staining on the teeth, so I like to link this back to the oral health education by showing them how improving the brushing technique and cleaning incidentally daily will not only control the biofilm, but it'll also help to reduce the staining. Behaviour change can be facilitated by goal setting, planning and self-monitoring. This includes identifying with the patient the change to be made, such as reducing the plaque score, and then planning with the patient to decide when, where and how, such as every morning before brushing the teeth in the bathroom, that's when we'll use the incidental brushes, and then encouraging the patient to assess their own behaviour in relation to the goal, such as using the disclosing tablets at home. I've found that this approach is particularly useful as it involves working with the patient on goals that are achievable for them and giving them the tools to improve their oral health and a way for them to see the improvements themselves. I used to think that I had to achieve perfection with my patients and that anything less would be a waste of time. I would bombard them with education, going over toothbrushing technique, incidental cleaning, adjunctive therapy advice, diet advice, smoking cessation, all in one appointment. And of course they'd go away completely bewildered and then come back without much improvement. It was just too overwhelming. What I've learned to do now is to keep it simple. Work on what the patient is already doing and build on that over subsequent appointments. A single episode of professional oral hygiene instruction leads to a small but statistically significant reduction in plaque and gingivitis, and there's evidence to suggest that additional effects result from reinforcement of OHI. The aim of the consensus was to reach an agreement of how we can support and maintain oral health in patients between appointments. If we can help our patients to control the biofilm, we can reduce the risk of both caries and periodontal disease. The advice that we give to patients needs to be consistent and simple to avoid confusion, elicit behaviour change and ultimately improve oral health. The consensus provides a simple recommendation that is easy for patients to implement into their daily routine, supporting oral health between dental appointments. For me, success is some form of improvement, no matter how small, whether that's a decrease in plaque and/or bleeding score or reduction in pocket probing depth. Even just a patient returning for subsequent appointments or asking me questions about their oral health shows me that they are engaged. And whilst it may take time to achieve optimum oral health, every step forward is a step in the right direction. Mechanical cleaning is the gold standard when it comes to biofilm management. Most patients know what they should be doing, but many struggle to achieve this. Evidence shows that most patients struggle to remove all of the plaque. And for some people, this is made even more difficult by reduced manual dexterity, malpositioned teeth, furcations, crown and bridge work, or orthodontic appliances. This is where adjunctive use of mouthwash can play a part. The recent S3 level evidence-based treatment guidelines for stage 1 to 3 periodontitis stated that mouth rinses appeared to produce statistically significant benefits in relation to plaque control, and that adjunctive chemotherapeutics delivered in mouth rinses may be more effective than brushing alone in reducing plaque levels, as they likely access more sites within the oral cavity. Therefore, for patients who struggle to achieve optimum biofilm management through mechanical cleaning alone, adjunctive use of a mouthwash may be beneficial.